Hi everyone and welcome and thanks for joining. I'm excited that despite being a COVID year, we can still put something on for Lung Cancer Awareness Month. And I think for some people this is probably a better way and it's a bit more convenient. But yes, a little bit of housekeeping before I get started. This, as I said, it's pre-recorded, so if you want to watch it a bit later, we will have the link to watching it later. If you need to get up and go, please do. Don't feel that you have to sit and watch the whole thing if you have to go to the toilet or whatever you need to do. You can ask questions via the Q&A button at the bottom. And when we get those questions, we will ask it at the end of each talk. And then there will be a Q&A at the end. And just to quickly introduce everyone, and I'll reintroduce them again before they talk, but we have a palliative care nurse here from Sydney Local Health District, Linda Foley, we've got a psychologist, Sarah Lorimer, a dietitian, Kim Alman, and Judith, Lacey from the supportive care team in the living room. Okay, so I'm going to share my screen now. I've got a little PowerPoint presentation. I'm just going to do a little bit of introduction to my role and a little bit about lung cancer. Okay, so I am, as you all know, a lung cancer nurse specialist, one of the very few in the country. I think there's 12 equivalent. So, can everyone see my slides, by the way? Yep, cool. So, what do I do as a lung cancer nurse specialist? My role, what I really try to do is to really tailor individualized support for each patient, because obviously each patient and everyone has their own individual needs, their own individual circumstances, and so yeah, we try and tailor it to what your specific needs are. Obviously I communicate between a lot of teams, and you know, the example is simply here from the people on the panel. They're just a few of the people that I talk very regularly with, and they're probably sick of seeing my face and getting my referrals a lot, but we do a lot of communication back and forth with each other. So yeah, I do work with a lot of teams because you know, everyone needs different things throughout their journey. And yeah, patient advocacy. So I'm trying to best support you as or our patients as much as possible in their lung cancer. I hate to say journey, but because it's such a cliche word, but in their journey. So a bit about what I do and, you know, the purpose of my role. And I think, you know, at the core of what I do, I want people to feel empowered, respected, and not alone. So obviously everyone, what they want through their cancer, the lung cancer experience will be different. And I just want you to feel that you've got all the information, all the support that you need to make the decision that's best for you. And how that looks is really different for everyone, as I've said. But as you can see that little graph, so obviously the patient and the family is at the centre of what we want to do, who we want to help and support and empower. And you know, there's all these people on the outside that will, you know, we're trying to help that. You know, there's a primary care team, so that usually is often the medical oncology team if you're having, you know, things like chemotherapy. But if you're having surgery, your primary care team would be the surgeons, for example. You've got the lung cancer nurse specialist, you've got the physician, the radiation doctor, the medical oncologist, the thoracic surgeons, allied health care team. Again, there's lots of people that are involved. Oops. Sorry. Some statistics, a bit about lung cancer, just as an introduction. And this isn't too recent, but this is fairly average statistics about how many people per day are diagnosed, which we say 34. It's roughly 4,900 males and 3,600 females that are diagnosed each year, or this year, predicting. 1 in 3 women and 1 in 10 men have never smoked. It is the 5th most common cancer. The Lung Foundation did some statistics about stigma, and there is still a lot of stigma about lung cancer, and it's something that we need to tackle and get on top of and do better about. There is most people are diagnosed fairly late stage, which is not ideal in terms of obviously outcomes, because we want people to be diagnosed earlier as possible. Lung cancer accounts for 9% of all cancer cases and 18% of deaths and mortality. And these are, if they're not fair, they're about 10 years old, this stage of diagnosis, but it just highlights the need that we need to have better screening practices, and we need to get people more at stage one and stage one and to be diagnosed so we can treat it better. So I just thought I'd go through the 3 different types of lung cancers that we mainly treat, just as an overview. So one of them is the non-small cell lung cancer. We've got small cell lung cancer, and we've got mesothelioma. Non-small cell lung cancer is the most common subtype. It is an umbrella to a few other subtypes, but I won't go into that for this talk, but it is the most common. For those that are diagnosed fairly young, this is the cancer that usually they're diagnosed with. It's often found at a late stage because our body usually compensates quite well, and their symptoms are quite vague, if there are any. And this is the cancer where in some cases it can be treated with a tablet if there's a mutation found, which is better than chemotherapy if you can avoid it. So the second cancer that we also do, which is quite rare or less common, is small cell lung cancer. It is generally associated with heavy smoking, although we have seen quite rare cases with people with no smoking history. It's generally more aggressive, but at the same time it responds quite well to chemotherapy, and radiation also works quite well in this population setting. And then the third kind of cancer that we do is the mesothelioma. So it's the cancer that's caused by the asbestos fibres, which usually sometimes can take 30 to 40 years to present. So if you're, for example, exposed when you're 20, you may not get mesothelioma until you can be 60 or 70. Sometimes, and that timeline will vary. And often they do have pain, one of the first symptoms, because there is pain receptors at the lining of the lungs, so they can, that's often how they do present with mesothelioma. And for my last slide, I just thought that this was put out by the Lung Foundation. It just highlights the need for resources and research in lung cancer, and sort of the goals that we have in it. It highlights the disparities between lung cancer and breast cancer and bowel cancer, for example. If you have a look at the screening program, there's a really good screening program for breast cancer and bowel cancer, but we don't have a very good one for lung cancer. And I guess there are many reasons for that. It's not very simple. Lungs are a bit different, and they have lots of other things going on. It's not as simple, often just feeling a lump. But we certainly we can, and we need to do much better in that space. And the screening program would help obviously increase diagnosis at earlier stages, and therefore it will increase outcomes. If you look at the last one, at the research investment, it's pretty abysmal as well when you compare to breast cancer and prostate cancer and specialist nurses. There's only 12 full-time equivalent lung cancer nurses, and I think we need more support. Our patients need more support, and so the Lung Foundation are advocating for that. So that ends my presentation. I will stop sharing my screen and see if there are any questions. No questions. Okay, I will introduce the next speaker. And if you think of questions for me, obviously we can talk about them at the end. There'll be a Q&A some questions. So our next speaker is our lovely dietitian, Alman, who obviously works at Lighthouse, and I refer a lot of our patients to see Kim, and she's a really great resource to help with lots of different things, not just weight gain, but I'm sure you do a lot of. So if you want to share your screen, yeah, go for it.
Yeah, no problem. So I'm just going to quickly share my screen. Can everyone see that?
Yes.
Beautiful. Oh, sorry. So as Amy said, I am Kim. I'm one of the dietitians at Lifehouse. There are a team of 7 of us at the moment, all looking at different types of patients who have cancer, different streams of cancer as well. So I'm the dietitian that Amy predominantly sends her referrals to, and we see a combination of inpatients and outpatients. So we see patients who have been newly diagnosed. We see patients who are either pre or post-surgical intervention. And we also see patients who are undergoing chemotherapy and radiotherapy, as well as patients who are undergoing immunotherapy as well. In terms of my role as a dietitian after a cancer diagnosis, there are a few things that we aim to achieve to help our patients through their cancer journey, as Amy said. So we do consider, our patients' individual needs, and we tailor a plan to meet those needs depending on the stage of our patient's cancer, what treatment they're undergoing, as well as environmental factors in terms of their living situation, if they are taking care of their own cooking and shopping and all of those things, to make a plan that really works for them. We do provide a lot of education and information about nutrition at each stage of the cancer journey, and we assist you to make informed decisions about your treatment. Sorry, I think one of the words has disappeared there on my screen. We provide strategies for managing symptoms and treating side effects, particularly for patients who are undergoing chemotherapy and radiotherapy. There can be some side effects that can really impact their ability to optimize their nutritional status. We promote overall well-being and health to tolerate those draining or quite invasive procedures and treatments. And we encourage patients to maintain a healthy weight and a balanced diet no matter what stage they're at of their journey. So in terms of nutrition and cancer, as I mentioned, my role as a dietitian really does change depending where our patients are at in terms of whether we're working in prevention, diagnosis, or during treatment, after treatment, whether that's in survivorship or if there is advanced cancer or palliative care. Those goals and strategies definitely change in terms of diet. It's not a one-size-fits-all approach. We hope to work with our patients depending on where they're at in that journey to provide them with the best and most appropriate strategies. And certainly in terms of the importance of good nutrition, some of the major benefits are things like improved energy levels, helping to maintain your lean body mass and strength, helping keep strengthening our immune system to fight infection, helping with your response to your treatment and potentially reducing that toxicity from treatment, helping with things like wound healing, overall health, preventing other lifestyle diseases that may be unrelated to the cancer but may just be part of your personal history, such as cardiovascular disease or diabetes, and again, maintaining that healthy weight to help prevent cancer recurrence. So definitely for those patients who may be undergoing treatment, there are a lot of things that may impact the ability to eat, and that may be things like taste or smell changes, a loss of appetite, fatigue, changed bowel motions, early satiety, that feeling of early fullness, issues with swallowing, or things like nausea and vomiting. And these are all, and it's certainly not limited to these things, and definitely depending, different things will affect different people to a different extent. So it really is, we encourage patients to talk with a dietitian to see if we can help change, to help fix some of those issues that you may be struggling with, depending on your individual experience. And one thing we are very conscious of is a high risk of malnutrition for those patients who are undergoing therapy. So what is malnutrition? It refers to having less energy and protein than is required. So with a cancer diagnosis, you do have higher requirements nutritionally. And sometimes it can be very difficult to meet these requirements. And certainly in the cancer population, there is quite a high rate of malnutrition. It's 26%. As you can see here, this can affect lung cancer patients as well as head and neck patients and our upper GI patients. So malnutrition can be quite detrimental in terms of things like recovery, mobility, the length of stay in the hospital, and how many times you're readmitted to hospital. So if there are things that we can do to prevent malnutrition, then we're going to try and do everything possible to do that. And I think there can also be a stigma that malnutrition is only visible when someone is very slim, very visibly underweight, but there certainly can be patients who are overweight or even have obesity and still be malnourished. So it is one of those things to keep an eye on over your journey to see kind of if you're struggling with any of those issues. Another thing that we definitely try and promote for our patients, because there is so much information out there, it's very quick to do a Google search, and come up with answers that may be suitable to you, or people promoting things that may not be evidence-based, we do highly encourage our patients first to seek advice from their medical team. If you are doing any research online using resources such as the Cancer Council, they have a really great website called iheard.com.au, which has a list of different myths related to cancer. So they're not only nutrition related, it could be a range of different topics that people commonly ask, and it's good to know what that evidence is behind that. And another website that we always encourage is the Memorial Sloan Kettering Cancer Centre. Bit of a mouthful, but if you do Google it, they've got a host of information available in terms of treatments, herb supplements, and different diets that may be appropriate or inappropriate for a cancer diagnosis. So we do encourage our patients to look for the evidence first before kind of leaning towards maybe those fad diets or a quick fix that may seem quite appealing in the beginning. And we do definitely recommend seeking tailored advice. As I've mentioned, depending on the type of cancer you have, even the subtype of cancer that you have within lung cancer, where you're at, what treatment you're having, where you're at in that journey can definitely impact the strategies that we put in place. So we do like to speak to patients individually. Obviously, group presentations are very helpful to give overall advice. But when it comes down to the nitty-gritty of it, it is really helpful to talk to patients individually. And whether you come and see us at, we have an outpatient clinic at the living room. Alternatively, if you see a dietitian in the community, always making sure that they're an accredited practicing dietitian, just so you know that you're getting the best possible advice. And that's my quick 10-minute thing. So I don't know if you have any questions now, or if Amy, you want to do them at the end.
Yeah, there's no questions yet. So we'll see if there's any in, we can ask them at the end.
Perfect. Thank you. I'll just stop sharing my screen quickly.
Yeah.
Thanks.
All right. Thanks. And that was great. And the next person who's going to give a little talk, it's a really important role, is Linda Foley from the palliative care community team, who often works with us to help us with our patients in the community. I definitely do a lot of referrals to palliative care to help and support our patients. It's a really different environment when a nurse goes into the home of a patient compared to when a patient presents to hospital. They often find out so much more than we could ever find out. So I think, and there's lots of other reasons and aspects of why it's really important. So I'll hand over to Linda, who's going to give a bit of a chat about what she does and tell us a bit more. Thanks, Linda.
Thank you. Yes, as Amy said, a lot of people don't know what palliative care is and what it can offer. And then when they start seeing a member of the palliative care team, they think, oh, I wish I'd known about this before. So for people who aren't aware of palliative care, it's an approach to care, and the World Health Organization talks about assessment, impeccable assessment of pain and other symptoms, support of the person and their family in their community. So it's really a holistic approach to providing care to people, not only people with lung cancer or cancer, but other diseases as well. So looking at that whole person, trying to provide what they need at the time that they need it. So it is about supporting the family as well. So for those reasons, a multidisciplinary team is used. So as well as nurses and doctors, social workers, occupational therapists, really important both in patient settings and in the community, in people's homes, and all of the services that are available depending on your location. So speech pathology, dietitians, et cetera, et cetera. Some areas have volunteer services, which are invaluable. But the idea is that all of these people are bringing their specialty to be able to provide whole care that the whole person needs. So not everyone will need specialist palliative care all the time. Some people may use it at the beginning when they're diagnosed for particular aspects. For example, some people might need more psychosocial support, and then other people might need more support with symptoms. So when we're talking about symptoms, pain's the one that's often thought of as a symptom, but of course things like breathlessness, anxiety, fatigue, all of those kinds of things is what we're trying to help people with. And a lot of the time we're helping people with this at home, in their own home. So people aren't in hospital most of the time. Most of the time they're living at home. And so we're trying to help them live as well as possible in their own home. So in the Sydney Local Health District, there are inpatient services and community services. Inpatient services include the hospitals, of course, consult services to all of the large hospitals in the district, and those specialist doctors also provide clinic, outpatient appointments. Then there's a palliative care unit, which is based at Concord Hospital. It's a standalone unit. It's really very lovely. If you have a look on the internet, you can see some videos of it. It's a really nice unit, set out really nicely and staffed by specialist nurses and doctors and social workers and physios and OTs, etc. And then the services in the community. So some people may have come across community nurses before, or wound care, or for oncology support. And in this district, it's the same nurses who are providing palliative care at home, but with the support of specialist palliative care nurses. So as well as the nursing care, there's doctors who are providing support at home, specialist palliative care doctors, also social workers, occupational therapists, etc., trying to look after that person at home in the way that they want. So if they're not wanting a lot of services, we step back into the background. And if things are changing, excuse me, and they're needing one, excuse me, and they're needing a little more support, then we step into the foreground as well. As well as the nurses and doctors, there's an after hours advice phone line. So if you're at home on the weekend, public holiday, and you've got a question about a symptom, for example, you know, I've got this symptom and I took the medication and I'm not sure how long I should wait to take the medication as well. You've got somebody that you can ring and talk to on the phone, talk about the options, get some support about what you might want to do next. The volunteer service also works in the community as well as in the inpatient units. And there's an equipment loan pool. Well, there's several actually. So for some people, being able to stay at home safely might just depend on having a few little key pieces of equipment, like a shower stool. So those things are available to help people stay at home and be safe at home. So in the community, the GP is still providing care to the patient, supported by the specialist doctors, but still pivotal in providing care. So that doesn't change when the referral is made to the palliative care specialist. The GP still remains in charge of the person's care. And that's basically it. Any questions?
No one's written a question, but that was, yeah.
Discussion at the end, maybe.
So yeah. We'll ask questions at the end, but no, there's none have come up just now. Yep. But I encourage everyone that is watching and listening to write some questions if you have any. We can always bring it up at the end. But no, that was really a really good overview. I think I had heard about the advice line, but it's really good to know too that they've got an after hours advice line. So there's always someone. Yes. And for our patients, we always have someone as well, but it's good to know they have another option if they need it. Thank you, Linda. That was awesome. Okay, so I'm going to hand over now to Sarah, who's our resident psychologist here at Lifehouse, who I know very well, and talk to her about, referring a few patients. So I'll hand over to Sarah.
So can you guys hear me okay? Cool. All right, I'll get my screen going. There we go. Can you see that okay?
Yep.
Yeah, okay. Yeah, so thanks, Amy. I'm Sarah. I'm one of the psychologists at Lifehouse. And basically today I'm just going to give a bit of an introduction around what is psycho-oncology and how can that help living well with lung cancer. So I suppose one of the first questions is actually, what is psycho-oncology? It's quite a big mouthful, and a lot of people haven't really heard that term before, or if they have, they're not sure what it is. So it's both like a clinical and a research discipline. So by clinical, I mean face-to-face with patients, having a chat with you about your needs, and research in terms of exploring how does cancer impact all aspects of a person. So it's a very holistic approach. We look at the cognitive aspects, so meaning the thoughts, emotional, behavioural, so what you do, and the social well-being of cancer patients, but also of their family and caregivers and friends. So we kind of look at cancer as not something that just impacts the patient, but also their entire family. And one lovely thing about psycho-oncology is that it's multidisciplinary. So we've got psychologists, but we also have specialist counsellors, we have social workers and psychiatrists as well. And we have all of those on offer at Lifehouse, which is really fantastic, which means we can kind of support all the different aspects of your psychosocial well-being. So for example, social workers can sometimes help out with complex family situations or financial support. Psychiatrists can help with medication, and psychologists and specialist counsellors can do therapy. Psycho-oncology is very broad. So a lot of people just kind of are like, what does it actually involve? Do I just come and talk to you about how I'm feeling? It's a little bit more in depth than that. So a couple of the things that we can do is a psychological assessment. So what that kind of involves is us helping you figure out what's going on. Is the reason for your distress, is it medical? Is it that you're really unwell? Is it a mental health issue? Is there depression or anxiety going on? Or is this just a normal emotional response to something really intense and really unexpected? And basically, once you've had a bit of an assessment, then we can figure out, okay, well, what can we do to help? So sometimes this is just having someone to talk to who's not in your friend or family circle, whose objective is just to process the cancer experience. So just to wrap your head around, how has this happened? What do I do now? What does this mean? Where to from here? Having a safe space to explore all of those kinds of questions. We also could give support with adjustment and coping. And by that, we mean kind of how do you come to terms with what's happened and how do you maximize your resilience with everything that's going on? So sometimes this can be navigating the medical system itself. Sometimes it can be coping with side effects of treatment, such as fatigue or pain or nausea. Sometimes this might be looking at how does cancer impact the other aspects of your life. So work, kids, family, friends, how you saw yourself, the exercise that you normally do, whether or not you can go to the beach like you used to do, all of those kinds of things. We also obviously deal with mental health issues. So sometimes cancer can trigger things like depression and anxiety, but sometimes people have those things before they come in. And so we can give support with that area as well. Grief and loss is also something that we deal with a lot. And this doesn't just mean bereavement. This can be grief and loss for things like, for example, if you're not able to work, there's a sense of loss that comes with that. Or if there's grief in terms of your life has changed in a way that you didn't expect or plan, and there can be kind of emotions that can be pretty painful around that we can help with. And we also do a lot of family and couple work. So as I mentioned before, we look at cancer as something that impacts the whole family, not just the person who's going through it. And so we see family members and we see partners and friends and things like that for support in their own right. So it can be quite stressful to be a carer for somebody. So how can we support you through that? And as well, navigating, sometimes family tensions can flare up or can come with cancer. It's complicated, takes a lot of time. There's a lot of navigating, a lot of decision making, so we can support with that kind of thing. Things like intimacy and connecting with your partner, all of that can be affected, so we can support you through that. And a big thing that we do a lot of is talking to kids about cancer. So we often see the parents, and we can have discussions on what's an age-appropriate way to talk to my child about this? How can I support them? What information do they need to know? What information do I not want to tell them just yet? Those kind of complex discussions. And this is probably just the tip of the iceberg. There's a whole bunch of other things that we can help with, just depending on where you're at. Another question that I get a lot is, what does therapy look like? A lot of people that we see have never seen a psychologist before and may never actually have come to see a psychologist if they hadn't been through a cancer experience. So a lot of the people that we see don't necessarily have a mental health diagnosis. So the media portrayals of psychology are not very accurate or helpful, but it does involve obviously talking. What the therapy actually involves and what type of therapy that you decide to do with a therapist really depends on your individual needs. It can be quite varied, but these questions that I've got up on the screen are kind of some common ways that we would maybe frame a session. So these are the questions that we help people kind of explore and answer. So for example, what can you do to rebalance or refuel? Like if you've got so much going on right now, if you've got doctor's appointments and treatments and sending emails to work and trying to talk to the kids, that can be really draining. So what do you need to incorporate into your day to be able to get through this and to kind of foster as much resilience as you can? Of course, lots of thoughts come up, often scary, dark, worried, angry thoughts come up when you go through something like cancer. Sometimes though, they can make you feel worse than you need to. So we can talk through strategies of how do you unhook from those unhelpful thoughts, and how do you shift your attention from, you know, worries and anxiety to focusing on what's important to you, which is one of the ones down the bottom there. So a lot of the work that we do is helping patients connect with what's important to them. So if there's a lot going on outside of your control, if it feels overwhelming, if it feels confusing, then we can kind of help you go, okay, but what is it that you value? What's important to you? How can we maximize that into your day-to-day to help you get through this really intense time? And a part of that is managing really intense emotions. Sometimes people who've never had anxiety before might get panic attacks, or people who've never felt depressed before start to feel really down and really low, just because it's a really big thing to adjust to. And so we can help people manage intense emotions and give them strategies for that. And as I mentioned before, talking to other people about cancer, sometimes this is kids, sometimes this is family, sometimes this is just colleagues and friends who may say sometimes very helpful or sometimes very unhelpful things as they try to support you. Sometimes people aren't sure what to do or what to say, and they're really good at saying the wrong thing. And so navigating those sometimes awkward conversations is something we talk about a lot. Another thing that's probably helpful to have a chat about is how to get the most out of therapy. So an average session, for example, is anywhere between 30 to 50 minutes, depending on what you need and where you're at and how well you are. And although that session might be helpful, none of the psychologists here are wizards, not that I'm aware of. And so a big part of therapy being effective is actually taking the suggestions and what's spoken about and practicing it kind of in your day-to-day. So for example, with that idea of the refueling, you know, if we talk about how can we incorporate just a walk or a little bit of sunshine into your day, making sure that you actually have the chance to do that. And if there's barriers that come up to that, that's totally fine. That's the kind of thing that we chat about as well. Again, probably contrary to how the media portrays it, psychologists and counsellors are not mind readers. So please ask us questions, be as curious as possible. And when we've written open and honest there, by that we mean like, just tell us what's on your mind. A lot of people hold things back because they're worried about being judged. So they go, oh, I don't know if I should say that. Maybe that's weird, or maybe that's offensive, or maybe that's strange. Don't worry about it. Just ask us questions and tell us what's on your mind, because the more we know, the more we can help. And a part of this is also expressing your emotions. So some people get embarrassed when they cry or when they feel upset or worried, and they try and hold it back. Don't hold it back, let it out. It's actually really therapeutic to have a cry. And coming to see a psychologist or a therapist is a really safe space to do that. So just show us your emotions. Don't worry, we can absolutely handle it. And a part of this as well is kind of remembering that we're working as a team. So we want to work with you. We're not going to tell you what to do. We're going to talk to you about it and try and be collaborative and supportive. And sometimes we might suggest things that seem a little bit strange, or we might ask questions that you're like, I'm not sure where that's going. You're always welcome to ask us questions back, and just be open-minded to see, are there different ways you could think about this situation? Maybe, maybe not. Are there different things that you could be doing to get through this and kind of foster as much resilience as possible? Maybe, maybe not. But being open-minded and curious is probably the best way to get the most out of therapy. That's probably the main kinds of information that I would kind of want to run through, because I suppose a big important part of this is it's really tailored and individualized. So it kind of depends on who you are and what your needs are and where you're at. But we can see if there's any questions at the end.
There is a question, and
yes.
maybe I'll bring it up at the end, and we'll get to Judith's talk first. If that's all right.
Sure.
Yeah. All right. That was great. Thank you, Sarah. That's really insightful. I think I can see why it really helps patients to process what's happening. And yeah, there's a lot that obviously happens when you're diagnosed with lung cancer, any cancer really. So I can see it's really helpful. And I almost wish everyone would see you, but they don't have enough resources for that.
Me too.
So I'm going to hand over to Judith Lacey now, who I think a lot of people know. She's our supportive care physician that works in the living room. She's very passionate about what she does and supporting our patients through the cancer journey. I'll let her talk more about what she does. All right, Judith, over to you.
So hello, it's really good going last, isn't it? Because I get to summarise and put this together a little bit, and that's really what we do in supportive care and integrative oncology. I will start by the fact that I'm going to hassle Amy to add an extra circle or two onto her fantastic multidisciplinary team diagram to include palliative care and supportive care, integrative oncology. And let's have a think about it. So I'll tell you a little bit about me, and then I'll tell you how I've been putting this together. So my background is I started off in general medicine and then retrained in palliative care more than 20 years ago now, and I've been working as with advanced cancer patients and with cancer patients for over 23 years. And I started about 5-6 years ago, I realised, well, actually, how fantastic. We've actually got to the point, and this includes lung cancer, where we're not only keeping people living longer with cancer, but we're actually continuing to find all these new and exciting treatments. All our symptoms and side effects of those treatments are quite different. We're more open-minded as a community as to how we support people with cancer. And there's also been this growth of this field called integrative oncology and another field called supportive cancer care, which really looks at the whole person and the impact of cancer on that person and how we can best expand our toolbox to really care for people. And so that's what I'm really going to talk about in lung cancer, because you know, lung cancer, and Amy mentioned this, lung cancer isn't 3 diseases or 5 diseases, it's a complex collection of diseases. Everybody's treatment is now personalised. Some people will be on targeted therapy, some people will receive immunotherapy, some chemotherapy, combinations of radiotherapy and surgery, go on to clinical trials. And so we need to understand what goes on for you and then meet you wherever that is. So supportive care, if you see it as this big umbrella, and all of us on this webinar are a part of that umbrella, underneath that umbrella. So if you imagine that on the top you've got all the disease modifying treatments, which will vary. All of us are here to support you and help every aspect of your well-being and every aspect of you to keep you living well and thriving with your cancer. Now, I will put under that umbrella psycho-oncology, nursing care, nutrition and dietitians, nutrition care, palliative care, holistic supportive care consultations, and a lot of the complementary therapies. And this is the interesting space that we're in the world at the moment, because we're finally finding more evidence to support some of the recommendations that people have been making for many years on how to actually enhance people's well-being. So if you look at some of the therapies so I'll start with some of the symptoms that people with cancer often develop. And we've heard from Kim and from Sarah about the interventions of nutrition and psycho-oncology, and I try and send all my patients to them anyway. But it's looking at what happens to a person when they're affected by lung cancer. And we often know, and everybody's different, but we often know that people develop symptoms in clusters. And so it's these clusters of symptoms. So you may have, and we use patient-reported outcome measures to score this and develop it. We find that we know in lung cancer, common cluster is breathlessness, anxiety and depression, loss of appetite, poor sleep, and fatigue. So how do you deal with all of that in one go? And so you need to sit there and you need to work with someone and tease it out and work out what's going on for this person. How do we develop a multidisciplinary, holistic approach that helps you manage these symptoms that can be connected? And the more research we do, the more we see that they really are quite connected. And how do we engage you and empower you to actually take the lead and move forward with some lifestyle modifications and some other recommendations that we may make. So the biggest one is fatigue. And fatigue and sleep disturbance we know is often related. We know that fatigue is a common side effect of chemotherapy. It's a common side effect of immunotherapy, of the cancer itself. If you lose weight and you're not eating well, you can have fatigue. If you're worrying and not sleeping well, you have fatigue. If you have advanced disease, you can have fatigue. So where's the evidence to support what we can do? And then we say to you, the evidence actually says exercise. So number one, first of all, you see your doctor, a doctor like myself or your general practitioner or your oncologist, and they look at, wow, is there anything in your bloods that we can maybe correct, something that's out of balance that we can improve your fatigue? So are you anemic? Is your B12 level low? Are you just running out of fuel because you have no iron? Are you not, is your thyroid function out? You know, all of these things are very relevant. Is your pituitary gland a bit off because of your immunotherapy? So we look at what we can correct and we correct it. And then we say, okay, what else can we do? And we say, well, actually, you need to exercise. You need to exercise from the time of diagnosis on. My God, exercising is really hard. Where do you start? And so that's where a lot of complementary therapies come in. And we know that massage can really help people feel relaxed and invigorated actually to improve their fatigue. And most of the studies are done in breast cancer patients, but there's actually high level evidence to suggest that massage can actually improve fatigue. And that's where our oncology massage therapists can really help. Imagine if you're all tight and you just feel feel bad all the time. You know, that's where massage can really help. And similarly, reflexology, acupuncture, which works on your meridians in your and using Chinese medicine diagnosis, TCM, actually has quite a high, it works totally differently in improving fatigue, moving your energy, reducing muscle spasm and engaging and improving your energy. If you're breathless all the time, you will feel fatigued. How do we improve your breathlessness and your fatigue? And the use of yoga and yoga therapy and breath work. I can't mention enough how important it is to breathe. So when we're talking about exercise, we can start with breath work with a yoga therapy one-on-one session or a yoga class, obviously in a skilled center, but learning how to open up your lungs, improve your oxygen flow, it relaxes you, getting your diaphragm down. And that's often overlaps very beautifully with Sarah's work in psycho-oncology, because as soon as you start focusing on your breath, it actually helps you relax, and it's a technique that many people will use. And so when you look at mindfulness-based stress reduction, for example, also very high level evidence to support people with fatigue and sleep disturbances and anxiety, part of that symptom cluster, we look at breath work and the importance of focusing on the breath and being able to allow thoughts to move and not remain in, allow you to experience the thoughts without focusing on them. I'm sure Sarah can talk more to the value of breathlessness, of mindfulness in managing stress management. And so you can see that what we do is we look at how do we empower a person to feel better, to manage their symptoms in a proactive manner, and then get you onto the treadmill and exercising, or onto the exercise bike, or if you've got disease in your bones, modifying your treatment with a personalised exercise program. So supportive care and integrative oncology is all about these non-invasive interventions outside of the box of traditional Western medicine and incorporating them very beautifully within Western medicine, within our the total care of a patient, independent of their prognosis. But I haven't mentioned herbs and supplements or repurposing of drugs, and I'm seeing who's on our group as well. But I think that these are topics and diet, and these are topics we really need to address. And so in my consultation, for example, don't be afraid to talk to your doctors about herbs and supplements you are taking, or herbs and supplements that you're interested in taking. I'm working now with one of our pharmacists to make sure that we check the safety of every herb and supplement that people are taking, rather than the blanket no, which is just not acceptable anymore. And so we really need to look at what's safe, what's effective, what isn't safe, and then the timing of using those herbs and supplements. There's also a big movement on repurposing drugs that a lot of people are talking about, using statins and metformin and mebendazole and different medications. And this is really coming from the UK, and looking at how people may be guided to do that safely if that's the wish. We really don't have enough evidence to support that as yet, but evidence is changing all the time. And finally, the importance of diet. A lot of people will change their diet. And what I suggest is, I do recommend some diet changes, particularly an anti-inflammatory diet, a whole food diet. But I think the most important is that diet is balanced and working together with the dietitian, so that if you are changing your diet, you make sure that you're getting all the nutrients you need, because lung cancer is often associated with muscle wasting. And so if you don't have enough protein in your diet, for example, you're on a Gerson diet and you've got no protein in your diet, how do you make sure that you have a balanced diet that supports your well-being, but also supports your ability to have control over your cancer journey? So I will leave it there so that we've got 10 minutes to answer questions or just have a discussion. Thank you.
Awesome. Thank you, Judith. That was great. Yes, we do have some good questions that have come from the audience, and I'll go through just each of them for the panel. First one's from Fiona. It's about taste and smell changes, I suppose mainly for Kim, about how to deal with that after chemo. What's your general advice for that one?
Thank you for the question, Fiona. So often with taste and smell changes, we do note, depending on where you're at with your chemotherapy cycle, depending on how many cycles you have, we find once chemotherapy is finishing up, those taste and smell changes do improve over time back to your baseline. However, managing it at the time can be really difficult, particularly depending on what those changes are. So for some people, in terms of taste, things may taste bland, metallic, bitter, sweet. So it really comes down to what those changes are for you, and potentially putting strategies in place to offset those changes. So particularly if you're finding foods are tasting very bland, it may be using different herbs, spices, condiments, things that are quite strong tasting to bring out those flavors. If foods are tasting very metallic, it may be that you're focusing on oral care, brushing your teeth after every meal, using a non-alcoholic mouthwash just to get rid of that flavor in the mouth. Certainly drinking plenty of fluids can be helpful. However, some people find, drinking water may have a shocking taste for them. So whether that's, adding things like cucumber, mint, or lemon to the water, choosing a sparkling water, or adding something like a sugar-free cordial to break through that taste can be helpful. So I think it definitely comes down to specifically what those taste changes are for you. And in terms of smell changes, can be very difficult to manage. Often people find choosing room temperature foods, maybe being out of the kitchen when food is being prepared, if a family member is preparing food for you. Sometimes the scent can be quite overwhelming when it's a hot dish. That's why we tend to recommend room temperature foods, or even cold foods, because they're not as full of scent. And hoping, I guess, depending on where you're at with that journey, that you may see a resolution of those symptoms. But certainly we can always have a one-on-one chat if you'd like, and we can talk through your specific taste and smell changes and some strategies to put in place. But hopefully that answers that. Judith,
and I would just add, absolutely perfect, Kim, and I would just add a few small things. If you do have problems with smell or the sight or smell of food, it could actually be a nausea type symptoms. So often some people get what's called a central nausea, which is nausea at the sight and smell of food. And so that sometimes an anti-nauseant can help, and a specific anti-nauseant. The other thing is, if you do have taste changes, it's really actually taking a history of that taste change. Some people will have a metallic taste. Some people, for example, if they've got an iron deficiency, will crave cold things, and actually correcting the iron deficiency can improve that. It's called pagophagia. And sometimes with the zinc deficiency, if you correct the zinc deficiency, that can improve the taste. Some people might have mucositis or sores in their mouth. So again, making sure there are no vitamin deficiencies, but also treating that proactively. But otherwise, everything that Kim said is absolutely fantastic.
Thanks, Judith.
Fiona, did you want to, I know she had your hand up. Fiona, did you want to say something? I'll give you a minute. I think I'm allowing it there. Wait. There we go. Sorry, I'm just figuring.
I'll just, while should I respond to Philip's answer about I mentioned herbs and supplements and checking lists. I will say that it's through me. So I'm doing this as a trial with our pharmacists at the moment. So don't send anything to the pharmacist. Just send me an email.
Also to that, Philip, I've often got pharmacy to double check too, so you can send it to me. I've been able to answer patients' questions that way as well. Okay, cool. For the next question, this one's for Linda. What is a palliative care after hours number? Now, my assumption is that you're given one when you enter the system, and I'll give you a specific one, but I'm assuming you don't just give out the number. I don't know.
Correct.
Enlighten us.
Correct. So that after hours service is for patients who are registered with Sydney District Nursing as a palliative care patient. Okay. So when the nurse first goes out to meet the patient and family, we talk about all the services, including the after hours service, when it's available, and the number is given then in writing so that the person can ring that number when they need to have a chat with the nurse.
Awesome. How many people usually sit on that desk hotline, or is it an on-call thing?
How many people are seen by our service for palliative care? No,
for the after hours contact number. Are there a few people on the phone lines, or is it people on call, or how does it?
It's one person at a time. So yeah, after hours, it can divert between the palliative care unit, so a nurse there will be answering it, yep. Or sometimes it goes to the intake service, so a nurse there will be answering the phone. Yeah, it's just one person.
Cool.
And it also depends on where you live and which service you're linked to, but you need to be linked to the service first.
Yeah.
Yes.
Cool. All right, thank you. Okay, next question, this one's for Sarah. Have you come across cases where people, and I'm sure you have, patients and family of those patients just don't understand why the patient has had enough treatment and they just want to stop? How do you, have you come across that? Can you talk more to that a little bit?
Yeah, so just to repeat the question, just so I make sure I heard it properly, did you say I come across cases where the family doesn't understand why the patient wants to stop treatment?
Yes.
Yeah, that is actually quite a common thing we come across. It can happen for a variety of reasons. So whether the side effects aren't acceptable or tolerable to the person, whether or not it's a curative or a palliative situation that makes a difference, whether or not the person may or may not be depressed. More often than not, that's not the case. It's often that the side effects don't feel tolerable. And so it's weighing up quality and quantity of life. And it can really come down to a person's individual values as well. So some people really value, for example, independence or living pain-free, whereas other people really value time and wanting to do specific things with different friends or family members. It's quite a unique kind of individualized situation, I guess. Yep. Those kinds of things are actually really good to come and have a chat with us about. So often we'll chat with the patient, or the patient and the family member, or just the family member as well. Obviously, we can't do anything to change anybody's mind about anything like that, but we can have discussions around, you know, do you need to talk through this so you feel like you've got an understanding of what's going on? Do you need any support coming to terms with or accepting or not accepting this person's decision, that kind of thing? Yeah.
And I also think it's a really important question with regard to, have you seen a palliative care specialist or a supportive care specialist?
Yeah.
I think it's really important to know that somebody has optimal symptom management, because if your symptom management is poor and your quality of life is poor because people aren't actually getting good control of your symptoms, you're just going, what the hell, what's the point of living like this? But if you had your diarrhea managed really well, and your fatigue managed well, and your pain managed well, and your nausea managed well, the world will look a lot different. And so in conjunction with the psychological side of, you know, managing depression and anxiety and I've had enough, it's also looking at how do we best manage your symptoms, and so that your quality of life, independent of whether you continue treatment or not, is the best quality of life you can possibly have. And that's really key to make sure that that person's been referred to palliative or supportive care.
Yes, I would absolutely agree with that.
Agree, Linda?
And Sarah, to keep you there, I mean, this sounds like a question that may be quite complex. You may not be able to answer it all in one sitting, but, you know, a specific example is what you said of patients who have had cancer and now cancer-free, but living in constant fear of relapse, and they just can't trust their bodies.
Yeah, that's a really common thing, actually. That's called fear of cancer recurrence, and that's such a common phenomenon that there's a whole field of research dedicated to that. So in terms of the way that we support people, it really depends how far out from treatment that they are. So for example, if you're only 1 month post-treatment, that makes perfect sense. You're still just completely adjusting and coming to terms with what's happened. And a lot of people's anxiety and fear of recurrence actually increases quite dramatically after treatment, because you shift from being in survival mode, just getting through the chemo, just getting through the immunotherapy, to, oh, now I don't have appointments for 3 months. Like, what if something happens? How will I know? And often that can have to do with how you were diagnosed in the first place. By that, I mean, if you had no symptoms and then you get quite a dramatic diagnosis, it's really hard to trust your body in terms of, well, how will I know what to look out for? How will I not know what to look out for? Those kinds of things. So the first year, I think someone said to me once, it's quite good to have a season of no cancer. So you want to know what it's like to have no cancer in summer, winter, autumn, spring. Go through the Christmases, go through the birthdays, and have a chance just to go through all of those things again. That is pretty normal to feel pretty anxious for about a year or so afterwards. But there's no, like, you know, there's no cutoff of like, oh, now it becomes abnormal. It really depends on your situation. But the types of interventions we might do would really differ depending on how far out a person is. Yeah.
Cool. Another question, is there a correlation between pain management and outcomes in treatment? I guess it depends. I'll answer that one quickly, but I guess it depends on what's causing that pain. Yes, if the pain's being caused by something cancer related, then potentially yes. But yeah, I think I might need.
See, I would see that question slightly differently. I think poor pain management there's no excuse for poor pain management, and it can be that you've left with chronic pain. A lot of the lungs and the lining of the lung is very sensitive, and you can get complex ongoing chronic pain syndromes post-thoracotomy. It doesn't mean your cancer is worse, but if there's a change in your pain, then we want to look and see, does that mean that there's something changing? So if there's a change in your pain, you see your doctor, you see the nurse, and you say, there's a change in my pain, let's talk about it. And we always ask those questions. So there are two different things there. Poor pain control, no excuse. You can't sleep well, you can't think, you can't eat, you can't interact with your family. Get your pain under control, see a specialist. But new pain, evaluate and see, talk to your doctor, see, does this mean something, so we can proactively manage it.
It's a really good point. So we've got all the questions. Does anyone have any more questions for the panel? We're at 10:33 now. All right. They all have been really good questions. So thank you everyone that's typed a question, and thanks to the panel for answering very well. I might close off the, oh wait, I think you've got one more. No, that was a thanks. So I want to just take the time again to thank the panel for coming on. It's been really good. I've learnt a bit about every one of you and what you do, so it's been really helpful. So hopefully if people want to watch it again, it'll be available and they can go over certain things. And if you want to get in touch, if anyone in the audience wants to get in touch with anyone on the panel, just let me know. I think you should all have my details. Yeah, and that's an easy referral I can do. Yeah, so thanks again. Thanks, everyone.